طبعا بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. نبدأ على بركة الله. I'll give you the instructions. Each speaker will have 12 minutes to present, and then there will be 5 minutes of discussion. The discussion will be by two panelists. We have made the distribution of the panelists according to the speakers. So each panelist will ask only one question. The question and discussion will take about 2.5 minutes. So total 5 minutes for the discussion. Then immediately we will move to the second talk and so on. Please, for the speakers, please be on time because there is a mark for finishing on time. The more slides you skip, the less the mark will be in this category. For example, if you skip 5 slides, you will take 0. If you skip, you did not finish 5 slides in the last, you will lose the 5 marks and so on. There will be an evaluation form. The panelists will do the evaluation for you. We will not announce for now the mark in this session. Later, we will do the evaluation in general, and then we will choose the winners. We will try our best to make it not only one winner per session, maybe 3 or 4 according to different categories. For example, best speaker, best talk, best idea, and so on. So relax. It is not a competition for exam. It is just to show us your skills and to reshape your skills. Of course, I have to thank very much the panelists who gave a big portion of their valuable time for you, for the young ophthalmologists, in order to reshape your science and you reshape your personality. We are sure that your teachers have done the best. We are sure of that. But presenting in front of audience is something which is not easy. We want you to be the top, inshallah. So we will start now with the first speaker. The first speaker will be Zainab bin Saeed. Let me first give. Yes. Now you can start sharing your screen, Zainab. The discussion panelist will be.
Assalamu alaikum.
Alaikum salam. The discussion panelist will be الأستاذ الدكتور محمود الشتاوي والأستاذ الدكتور عصام الطوخي. And the rest will be evaluators. Dr. Zainab bin Saeed from Algeria. Most welcome. Please start your presentation. I'll start the timer. After 12 minutes, I'm going to stop the presentation. Okay?
Please.
Yeah, I will not start until you. I will not start until you start.
Until I. تمام. ممكن أبدأ يعني حاليا.
Yes, we can see now. You can start. Bismillah.
Thank you. So, Bismillah ar-Rahman ar-Rahim. I'd like to thank you so much for this opportunity, and to tell you how grateful I am for this. Thank you so much. So today I'm going to present a clinical case about the management of ocular surface squamous neoplasia. The management of OSSN with topical chemotherapy or surgical to choose, and when and what to treat. So before we start, we have to know that what is an ocular surface squamous neoplasia. It's an umbrella term that defines a varied spectrum of diseases which can range from dysplasia It can be mild, moderate, or severe to invasive carcinoma that can involve the conjunctiva and or cornea. Why it's important to discuss this subject? Because it's the most frequently encountered non-pigmented tumor of ocular surface. And besides, worldwide, the incidence rate of OSSN is highest in the Southern Hemisphere. It means with peak incidence is in Africa, where I am from. So it's generally a common reason for consultation. And the management modalities in OSSN range from complete excision in well-delineated tumors to surgically excision in diffuse lesions. So now let's get started with our clinical case that I'm going to present today. It's about a 50-year-old woman presented with complaints of growth on her eye for 6 months, which was progressively growing, in size and associated with redness, hypophora, and mild pain. She didn't have visual complaints. The patient had an eye consultation earlier where she was diagnosed as a case of pterygium and treated with lubricants only. However, she noticed that the growth had progressed rapidly over the last 3 months, for which she was referred to our institution for medical care. There was no history of trauma, surgery, or ocular diseases in both eyes. The patient had no history of systemic diseases and was not prescribed by medications recently. The general and systemic examination of our patient were within normal. There was no regional lymphadenopathy. Ocular examination revealed that the best corrected visual acuity was 6.6 in both eyes, and slit lamp examination of the right eye revealed a diffuse conjunctival hyperemia. And as we can see here in this image, an elevated conjunctival mass with limbal involvement from 1 o'clock to 8 o'clock, extending 2 millimeters into the cornea and infiltrating the nasal part of the conjunctiva, as we can see here, extending even into the canthus. The lesion was fleshy, papillogelatinous in appearance, translucent and grayish, and vascularized with irregular vascularization pattern, giving the shape of red dot, or what we call strawberry pattern. Associated with conjunctival vascularization, we can see here the presence of 3 feeder vessels at the top, middle, and base of the growth. Cobalt blue light using fluorescent drops to highlight the tumor showed punctate keratinopathy in the upper and paracentral parts of the cornea, which weren't seen before. The examination of the left eye was completely normal. Intraocular pressure was normal in both eyes. Ocular motility and cornea sensibility were without anomaly. Gonioscopy examination revealed open angle in both eyes without involvement of angle in the right eye. And fundus examination was normal in both eyes either. And in the view of the fact that a lot of studies have shown that HIV and HPV serology patients have a higher rate of developing OSSN. We demanded a serology of HIV and HPV for our patient, and they were all negative. And then optical OCT tomography has been employed as in vivo diagnostic modality in the evaluation of OSSN extension. And we can see here a cut passing through the tumor revealed an abrupt transition between the normal and abnormal epithelium, as well as epithelium thickening and hyperrefractivity in the area of the tumor with a posterior acoustic shadowing. The rest of the corneal mapping was completely normal. Also, a biopsy of the tumor was performed to confirm the diagnosis of OSSN. Here we can see a global disorganization and a lot of dysplastic, cellular dysplastic. And the histopathological result showed keratinized, well-differentiated, invasive squamous carcinoma. In front of these results, our patient was treated with mitomycin C, 0.04%. We used a protocol of 5 cycles of 1 drop 4 times per day during 2 weeks on and 1 week off. After the second cycle, cytolysis of the tumor started, as we can see in the upper image. By the end of the first cycle, the tumor was no longer visible microscopically, as we can see in the low image. And the 5th cycle was performed to sterilize the lesion site from any persistent carcinoma cell. During therapy, our patient complained of epiphora and irritation that were rapidly relieved by prescribing preservative-free lubricant eye drops and steroids. By the end of the treatment, the right eye of our patient was completely clear, and the patient was followed up monthly for 3 months, then every 3 months after that. Unfortunately, after 1 year, our patient examination revealed a recurrence of conjunctival mass in the right eye, as we can see here, at the upper nasal part with high suspicion of malignancy. Another biopsy was done and showed a recurrence of squamous invasive carcinoma. At this time, we decided to do chemoreduction with mitomycin C, followed by surgical excision, no-touch technique, and conjunctival autograft transplantation from the left eye were performed. And here we can see the excision tissue sent to histological study, where showed that there were three nodules masses, which sizes varied from 2 millimeter to 4 millimeter, and confirmed the presence of epidermoid well-differentiated carcinoma with the limits of the excision were without any anomaly. And for that, we decided to interrupt the treatment by mitomycin and to only prescribe steroids and lubrificants for 1 month. At 6 months now, the eye of our patient has no tumor. Nevertheless, we can see a residual opacity in the upper nasal part of the limbus. So now, passing to the discussion, discussing the most important point in our clinical case. The gold standard of treatment of ocular surface squamous neoplasia has traditionally been surgical excision with wide margins and no-touch technique. However, surgery may be associated with several unfavorable skills, as well as significant recurrence rate if margins are positive. And in recent years, topical chemotherapy is becoming the preferred approach in treating surface lesions, especially for diffuse, annular, or multifocal lesions, which are difficult to manage surgically. And this is why we choose to treat our patient with mitomycin C at the first time. So chemotherapy is varied. There is 5-fluorouracil, interferon alpha-2, and mitomycin. For us, we choose mitomycin C because it's available. So we're going to talk a little bit about mitomycin C, which is an anti-metabolite originally isolated from an antibiotic. Its anti-neoplastic and antibiotic properties make it useful in glaucoma, pterygium, also used as an adjuvant therapy in OSSN, excision surgically, and even treating medically OSSN. Mitomycin C is generally used in the form of topical eye drops in concentration of 0.02% or 0.04%, but studies didn't show really the difference between the two concentration to remission or recurrence rates among the two are the same. And many different administration regimens of mitomycin have been studied. So we can use mitomycin in 4-week cycle, 4 times a day for 1 week, followed by 3 weeks of no treatment with cycles repeated until resolution. Others may use mitomycin with shorter breaks or longer consecutive days of treatment. The main drawback of mitomycin is the intensity of its side effects. So mitomycin have adverse effects include redness, itching, tearing, pain, corneal erosion, hyperemia, punctate staining of cornea, punctual stenosis, and limbal stem cell deficiency. In order to alleviate these effects and prevent severe toxicity, patients are commonly instructed to use steroid and preservative-free artificial tears throughout the course of treatment. Also, a recurrent OSSN is it's an emergency case. Why? Because a recurrent OSSN can grow rapidly and be more invasive. And generally, it's a local invasion, but rather than widespread systemic metastasis. For this, recurrent OSSN needs to be treated with aggressive medical, surgical, or combination therapy. So in conclusion, topical or perilesional chemotherapy on the ocular surface as a single therapeutic agent has proven to be an effective treatment, avoiding the risk of repeated surgical interventions and their effects such as scar conjunctival changes. But no consensus really exists. Nowadays, there is no clear guidelines in how to use and what to use and what's concentration to use. This is why it's really important to have larger controlled, this is why it's very important to have larger controlled studies with longer follow-up periods are recommended to confirm long-term efficacy and safety of this treatment. And those are my references. Thank you so much for your time and for your attention.
Thank you very much, Dr. Zainab, for finishing on time. Fantastic. Now we start the discussion. Ustaz Dr. Isam Touhi.
Thank you, Dr. Mazen. Thank you, Dr. Zainab. Why do you call it recurrence if it occurred after 1 year? This is my first point. The second, now after 1 year and after the recurrence and after other 6 months, if time returns back, would you adopt the same regimen that you used in the first place, or would you have started with surgery or chemo reduction followed by surgery?
Okay, thank you so much. Can I answer? Okay, I will answer then. For the first question, 1 year we can have recurrence of carcinoma even after years of treatment, coming to 5 years. 1 year is really a short time, and it's practically the same part, the nasal conjunctival part, and the histological study showed that it's the same carcinoma, the same type of carcinoma. This is for the first question. For the second question, yes, we would do the same thing, because we we wanted to do a chemo reduction, then to have surgery. But from the first cycle, our patients started to have cytolysis, and there were no place for surgery. So we decided to continue with chemotherapy and to see the evolution. Now maybe we would use cycles. We can go in theoretically we can go into 8 cycles. I think maybe if we come back, we would go to 6 or 7 cycles, maybe, to sterilize the ocular surface from any persistent stem.
Okay.
Done, Dr. Isam?
Yes, thank you.
Thank you. الأستاذ دكتور محمود شتاوي.
أهلا دكتورة زينب، دكتور مازن. I just want to ask, it's quite a good presentation, but I just want to say it is common in Africa. Which part? You didn't indicate which part of Africa. Is it common in Algeria or not? What percentage is present? And regarding your reference, you didn't have much reference precise for the case. You just a few things, you know.
I didn't hear well. What did you say, sir? For references?
Sorry, yeah. First about, I say thank you and everything, what you have, but yeah. I'm saying about, you said it's common in Africa. So you didn't indicate how much percentage in Algeria, for example, and which part of Africa it's quite common. This is first. The second thing is reference is a little bit, you know, missing few other important bits.
Okay, so in Africa, it's common. The study, let's see, the study showed has been done in southern in Africa, but not in southern hemisphere, especially in Africa, in the southern part of southern. How to say?
بالعربي you can say بالعربي.
تحت الدول الاستوائية. شكرا. تحت الدول الاستوائية. Equatorial, yes, from 30 to 30 degree to 0 degree خطوط العرض. عن خطوط العرض. This is in Algeria. Unfortunately, we don't have really specific statistics, but it's a common presentation. For example, I have a short experience, and till now we have treated for about 30 for ocular surface in general, not carcinoma, not invasive carcinoma, ocular surface in general for about 30. But statistics in Algeria are not done. This is why I wanted to highlight this subject and to follow this road.
Okay, thank you. Thank you.
Thank you very much. And we are on time. Now we move to the second speaker, Dr. Dunya Ali Al-Mutayri from Yemen. Are you ready?
Yes. Yes, I'm ready. Hi. Okay.
Yeah, please start sharing your screen.
Okay, well.
You will be discussed by الأستاذ الدكتور إبراهيم العدوي الأستاذ الدكتورة سمية الحنفي.
Okay.
Are you able to share your screen?
Yes, yes, I will. Can you see my screen?
Yes. Bismillah.
Oh, okay. Bismillah. Welcome to my presentation. I'm Dunya Ali. I'm a resident ophthalmologist, second year of Arab Board. First of all, thank you all for coming here today. Thank you for Dr. Sinjab and all the doctors here and iTeach team for this opportunity. As we can see on screen, my topic today is Kaposi sarcoma is rare or uncommon disease, but there is case presentation. Why isn't move? Yes. A 60-year-old female patient with type 2 diabetic reported to outpatient clinic complaining of conjunctival lesion in left eye. On examination, visual acuity in OD 20/20, in OS 20/100. IUB within normal in both eyes. Ocular motility was normal. She had nuclear sclerosis in left eye. Fundus examination was normal too. On conjunctival examination, as we see in this picture, the conjunctival lesion 6 by 7 millimeter in diameter, elevated, bright red, dilated anterior blood vessels, and surrounding telangiectatic vessels. On a blood test and serological test, CBC and HbA1c were normal, but HIV was positive. As a differential diagnosis, Kaposi sarcoma, OSSN, ocular surface squamous neoplasia, squamous cell carcinoma, and lymphoma. Excisional biopsy with safety margin 3 millimeter and cryo was done by the Dr. Tariq, and I was an assistant. On histopathological results, the large aggregation of dense Beckett spindle cells with hyperchromatic nuclei. Actually, this picture from Medscape wave, as we see the spindle cells here. Unfortunately, the patient the patient know her diagnosis and she disappeared. Most likely diagnosis here is Kaposi sarcoma. What is the Kaposi sarcoma? Kaposi sarcoma is a vascular tumor that typically affects individuals with AIDS and associated with human herpesvirus type 8. On ophthalmic presentation, most frequently involve eyelid lesion are 6 to 16%, in conjunctival lesion 7 to 18. In eyelid lesion involve upper and eyelid equally, but in conjunctival lesion in inferior conjunctiva more than superior conjunctiva. There are 4 classification of clinical ophthalmology. Is a classical type more commonly in elderly patients. African is a more aggressive, and in young patients younger than 40 years, it's associated is epidemic and heterogenic transplant associated. Also, the etiological agent of 3 others related to lymphoproliferative disorders, primary effusion lymphoma, plasma cells variant of multicentric Castleman disease, and vascular recurrent enjoy lymphohyperplasia with eosinophilia. About the life cycle of Kaposi sarcoma herpesvirus, there are 2 phases, latent and lytic replication. About the latent infection is the only limit number of Kaposi sarcoma herpesvirus gene are expressed. The switch between them by epigenetic factors or oxygen reactivation like hydrogen peroxide. The induction of lytic replication by multiple factors as environmental or chemical stimuli. As we see this in this diagram, multiple factors, cytokines, AIDS, and herpes, human herpes virus type 8 lead to the Kaposi sarcoma. Okay, about the history, identify the risk factor for Kaposi sarcoma, demographics. As we mentioned before, it is important about the age and the countries. Immune status, we should ask the patient if he has any immunosuppressions like cancer, like a diabetic, and also ask about previous skin lesion, previous treatment for Kaposi sarcoma, history of opportunistic infections like HIV, human herpes virus type 8, or current medication use as a chemotherapy or use your steroid for a long time. So we should do full ocular examination. In general, the lesions are purplish red to the bright red and highly vascularized with the surrounding telangiectatic vessels. They may be macule, plaque-like, or nodular. Ophthalmic Kaposi sarcoma lesions commonly found on eyelids, conjunctiva, caruncles, and lacrimal sac. They are rarely found inside the orbit, so representation as a proptosis. As we see here, as up to date, Dwell et al. Described the direct therapy, help to the direct therapy. As we see in the above image, stage 1 and stage 2 tumors are patchy and flat, and the lesion have thickness less than 3 millimeters in vertical height and younger than in 4 months. But in below picture, we saw the stage 3. Stage 3 tumors are nodular and elevated. The lesion have thickness of greater than 3 millimeters in vertical height and older than 4 months. This another picture from PubMed in the periphery, the stage 3 in the middle, in the stage 1. Also, we can do also a serological test for HIV, ELISA, and CD4 T lymphocytes, and also the definitive diagnosis is histopathology. As according to Dwell et al. Described for Kaposi sarcoma type 1, appear like thin and dilated vascular channels are lined by flat endothelial cells and lumen-containing erythrocytes. Also, the cells have flat endothelium, a fusiform nucleus, and scanty cytoplasm. Moderate monoocular cells infiltrate surrounding the abnormal vessels. No spindle cells or slit space are observed. But about type 2, plump and fusiform endothelial cells line thin, dilated empty vascular channels. Many of these cells have hyperchromatic nuclei. Inflammatory infiltrate is sphere, foci of few immature spindle cells, and early slit vessels are present. About type 3, as our case presentation, the large aggregation of dental packet spindle cells with hyperchromatic nuclei, mitotic figure, and abundant slit space here containing erythrocyte and inflammatory cells are scanned. As we see in this picture, we saw in the right eye, unfortunately, I didn't find the histopathology for type 1 and type 2, only this in type 3 in the spindle cells. In right picture, we saw H&E stain with magnification of spindle cells. In the left image, we saw human herpes virus type 8 with the spindle cells. Okay, now we will move to management. We should manage or treat HIV, Kaposi sarcoma, sensitive chemotherapy. We can use combination or single therapy. Intralesional chemotherapy, interferon alpha-2A or alpha-2B, administered in subconjunctival injection adjacent to the tumors. About the surgery, surgical excision and cryo, conjunctival tumor, Dwell et al. Recommended the effective treatment regimen based on clinical and histopathological stage of the tumor. If the lesion is stage 1 and 2, confined to the bulbar conjunctiva, excisional biopsy with 1 to 2 millimeters clear margin is suggested. If the lesion is stage 3, surgical excision guided by fluorescein angiography, delineation of the tumor margins. Alternative treatment can include intralesional mitomycin or intralesional injection of interferon alpha-2B. There is the note here, if the patient has already systemic involvement that required chemotherapy, the eye lesion over resolve or it is reduced markedly after starting this therapy. However, recurrency commonly follow after discontinuation of chemotherapy. If the local treatment is indicated, the fear for at least four weeks after systemic chemotherapy to allow for regression of this lesion. Consultation workup is necessary to rule out systemic involvement and HIV/AIDS infection. Refer to internist and oncologist or chemotherapist, bronchoscopic, sigmoidoscopic, and lymph node biopsy for definitive diagnosis and systemic chemotherapy according to disseminated Kaposi sarcoma. Take-home message: differential diagnosis of Kaposi sarcoma in risky patients. Workup is necessary to rule out systemic involvement and HIV or AIDS infections. We have to alert local health authorities. This is my reference, and thank you for your attention and listening. Thank you.
Yeah, thank you very much for being on time. Now we open the discussion. Please, الأستاذة الدكتورة سمية الحنفي.
Assalamu alaikum rahmatullah. Very good, well presented, Dr. Dunia. But I have two questions here. Why do you put Kaposi sarcoma on top of your differential while it's a very rare disease? And why you do HIV test? Is it routinely done for any ocular surface disease or patient is known to have HIV? Because it's more common to have a squamous cell carcinoma rather than Kaposi sarcoma, unless patient is immunocompromised. Other questions: why you didn't do imaging to rule out other differentials or extension for most common differentials in this case? Thank you.
Okay, thank you, doctor. First of all, for Kaposi sarcoma, I put the differential diagnosis because this patient pre-op, we accidentally appear it's HIV positive. After that, when histopathological results like spindle cells, large aggregation packet of spindle cells, this is confirmed the patient HIV. But about the patient, why we didn't do for her another investigation and image, because unfortunately the patient when the patient knew her disease, she disappeared. So we can't complete the treatment for patient and work up for her. And that's it.
Thank you, Dr.
Welcome, doctor.
Dr. Sumaya, you are fine with the answer?
Yes. Thank you.
شكرا. الأستاذ دكتور إبراهيم عدوي.
أيوة, السلام عليكم. Thank you for this very good presentation. I will ask you, is it common in your locality, in your regions, and is it limited, the ophthalmic Kaposi sarcoma, is it limited to the eyelid conjunctiva only, or could affect the orbital tissue, intraorbital lesion? Could it happen, and how to diagnose?
Okay, thank you, doctor. For first question, actually, until now, 3 cases recommended in our country, recommended by Dr. Tariq, but the other questions about it's not only for conjunctiva, only in the eyelid and lacrimal sac and caruncles, rarely found as studies or research. Inside the orbit rarely appear. But in the eyelid lesion, recommended cases like 6 to 16 cases, and also in the eyelid lesion, maybe do like a complication, like the patient complained that like ectropion, entropion, and trichiasis, and lead to the complication. So the patient came with another manifestations. Okay, thank you.
Okay, thank you.
Thank you, doctor.
Great, thank you very much. And now we will move to the third speaker, Dr. Athir Muhammad Atiq from Yemen as well. The board member who will discuss you are Dr. Tariq Al-Dais and Dr. Bara Al-Qubisi. Are you ready?
Yes, I am ready.
Yeah, so please share. Your voice, we cannot hear you very well.
My screen.
There is internet connection issue. So you can switch. Yeah, you can switch off your video if you wish to make it only voice. Maybe it would be better.
Okay. Is it good now? Do you hear me well?
Still, the voice is interrupted. So try to share your screen now, please.
Okay, I'm trying to share it. Is it shared with you?
Sorry, not yet. Not yet.
Not yet. No.
Shared now?
Yes.
Okay.
Yes, we can see your screen now.
Shall I start?
Yes, please. Bismillah.
My voice, is it good?
Yes.
You hear me well?
Yes.
Good evening, everybody. It is a pleasure for me to be lecturing with you today, and I'm very thankful for this opportunity. Thank you for Dr. Mazen Sinjab Academy and iTeach Academy for having this chance. My presentation today is about IgG-related orbital disease, which is an inflammatory disease. I am Dr. Atir Muhammad Atir, ophthalmology resident, Arab World and Health specialization from Yemen in my second year of residency. Let's start talking about IgG4 related orbital disease. Is it moving the slides or not? Yeah. Let's start first of all about definition. What is IgG4 related disease? IgG4 related disease is a systemic condition at which fibroinflammatory lesion, which is in form of fibrosing lesion rich in IgG4 plus plasma cells present in single or multiple organs. When it starts to manifest in the eye or the orbit, it is referred as IgG-related ophthalmic disease. First, it was discovered in frequency of location. For the most common involving site is lacrimal gland involvement, which is responsible for 80 to 60% of involvement, orbital fat, and also extraocular muscle involvement and trigeminal nerve involvement. IgG4 related disease was firstly discovered in autoimmune pancreatitis patient in 2001 in Japanese literature, where they found that the extraocular muscle or the orbital and lacrimal gland muscle involvement was the first extrapancreatic site of involvement of this systemic disease. So what are the risk factors for having IgG4 related disease? It is more in male patient and it is more in younger group patient. Also, it is more in salivary gland lesion and higher serum IgG4 levels. It is also increased the risk of developing non-Hodgkin lymphoma compared to patients with systemic or pancreatic form of this disease. Also, atopy play a role in the development of the disease, such as asthma and allergic rhinitis. On the pathology of this disease, we have three major pathological criteria for the diagnosis. First is dense lymphoplasmacytic infiltrate, as we see in picture number 1, and picture number 2 talks about focal stertiform fibrosis, which is the other criteria. And the last criteria is obliterative phlebitis, as we see here in the picture number 3. Actually, 2 of these criteria are evident or enough to make the diagnosis of the disease. It is not mandatory to have all 3 together. We have also another clinical presentation for this disease. It most commonly involves, as I said before, lacrimal gland in the form of dacryoadenitis, as we see here in this picture, number A and B. Also, it may be presented as an eyelid swelling, either unilateral or bilateral. As here, we can see there is a bilateral involvement of eyelid. Previously, it was referred as a Mikulicz disease before the discovery of the IgG4 related disease as a unique entity, which is bilateral lacrimal gland involvement and bilateral salivary gland involvement. Also, extraocular muscle involvement is very important. It is presented as proptosis or restrictive strabismus or even diplopia. Compared to traditional idiopathic orbital inflammatory disease, IgG4-related orbital disease tend to be bilateral and lacrimal gland involvement, and it is more likely to experience recurrence after treatment and less likely to achieve complete remission. Mass effect lesion from inflammatory lesion may result in compressive optic neuropathy or even infraorbital nerve enlargement. We have a criteria to diagnose this disease. We have to put all these criteria actually together. It is 1, 2, and 3. We will talk about everyone in details. The first element is imaging studies, which shows enlargement of the lacrimal gland and hypertrophic lesion in various ophthalmic tissue. Number 2, histopathology, and histopathological studies shows marked lymphoplasmacytic infiltrate and sometimes fibrosis. Also, it shows IgG4 plus level plasma site in a ratio more than 40%, or it must be more than 50 in high power field for IgG4 plus plasma cells. Hematological studies shows elevated serum IgG4 level more than 135 milligram per deciliter. So we can say it is a definitive disease when 1, 2, and 3 all present together. It is a probable disease when 1 and 2 present, and it is a possible disease when 1 and 3 only present. Other diagnostic procedures include imaging studies, which is CT scan, MRI, or shows orbital soft tissue or extraocular muscle involvement. Here, as we see in this picture, there is an left inferior oblique muscle involvement and enlargement associated with left infraorbital nerve enlargement as showed by arrow. MRI will demonstrate iso-intensity lesion in T1 and the hypo-intensity lesion in T2, or it may be homogeneous lesion in gadolinium enhancing. Other diagnostic procedure, and it is the main stay of procedure, is surgical biopsy for the involved tissue, mainly lacrimal gland, which is the most commonly involved, and sent for histopathological diagnosis. Other laboratory tests shows elevated serum IgG4 level, although it is not necessary for the diagnosis. 40% actually of patients which are biopsy proven have normal IgG4 level. It helps in guidance of the disease and recurrence, tell us if there is flare up or not. We have to put all criteria as I have said before, to diagnose this disease. For treatment, we have a medical therapy, which is induction therapy by steroid, prednisolone 0.6 milligram per kg per day, or starting dose 30 milligram per kg for up to 2 to 4 weeks, then tablet over 8 to 12 weeks. We can use also intralesional steroid, as we see here, dramatic response after injection of triamcinolone for this patient. If there is a relapse, we can use a disease-modifying agent, which is rituximab, which most commonly used and have the higher response rate. Other immunosuppressants such as azathioprine, mycophenolate also. Medical follow-up is necessary for the patient, as over half of patients have a systemic disease or involvement. Follow-up with rheumatologist to assess extraorbital site involvement. Workup include liver function and renal function test, as it targets liver and kidney more commonly. CT scan to exclude mass lesion in this area. And imaging studies recommended when there is a high level of serum IgG4 level and bilateral involvement, which tends to have systemic involvement in these cases. Surgery, actually, it is not necessary for this patient. It doesn't help. We can use our start surgical therapy if there is only vision-threatening symptoms from mass effect lesion, unless it is well response to medical therapy. My home message is, in case of ocular adnexal involvement, unique clinical histopathological feature delineated for this disease, careful clinical and radiological examination, also investigation for other organ involvement, long-term monitoring for the disease, and potential recurrence, and potential also neoplastic transformation may be required. Those are my references, and thank you.
Fantastic. Thank you very much for finishing on time. And now we will open the discussion. الأستاذ الدكتور طارق الدعيس. We cannot hear you, and we cannot hear you. Still, we cannot hear you.
الآن تسمع صوتي؟
نعم.
Okay.
تفضل.
Thank you for this nice presentation, Dr. Athir. I want to ask you about what's the typical clinical features of IgG4 and how can you differentiate it from other orbital inflammatory disease like pseudotumor cerebri? Dr. Athir?
Okay.
Dr. Athir, we cannot hear you. Please switch off your video. Dr. Athir, please switch. Dr. Athir, switch off your video.
The main clinical presentation actually for this disease is less effective. I've switched it off. Do you hear me now good?
Yes.
Do you hear me now?
Yes.
About the question of the clinical presentation, Dr. Tariq, actually the mainstay of clinical presentation is the lacrimal gland involvement in IgG4 related disease. Also, it may be presented as soft tissue involvement, fat, orbital fat, or even extraocular muscle involvement. It will be presented as proptosis, restrictive strabismus, or even diplopia. In how to differentiate it from the other disease, it's a unique clinical pathological study helped to differentiate it from other disease. Also, we have criteria which is have to put all elements, imaging studies, radiological studies, and laboratory or histopathological studies to diagnose this disease. Actually, patients with IgG4 related disease tend to have more recurrence and more relapse after treatment and tend to have bilateral involvement instead of the other. That's the answer of the first question, which was what is the second?
So, Dr. Tariq, you are fine with the answer? Okay. Dr. Bara?
Thank you, Dr. Athir, for this great presentation. I have two questions for you. How do you differentiate orbital inflammatory disease in general from thyroid eye problems, especially when the muscle is involved? Second question is, you mentioned at the beginning and during the lecture that you must have a biopsy to do pathology. So whenever we have a lacrimal gland enlargement, is it safe to do a biopsy, or we should put some considerations in our mind?
Okay, thank you, Dr. Bara. For the first disease, first question, which was how to differentiate between them. Yes, is it that?
Yes.
Yeah. As I said, it is how to differentiate between grave and idiopathic orbital inflammation. Actually, in grave disease, it tends to have extraocular muscle involvement, which result in restrictive strabismus, which is more prominent than patient with idiopathic orbital inflammation. In patients with idiopathic orbital inflammation have high levels of increased IgG4 level. In patients with grave will have increased thyroid function test T4 and TSH T3 also. For the next question, actually, lacrimal gland biopsy, we have to avoid it as possible because it may result in long-standing problem and destruction of the lacrimal drainage for the lacrimal gland. So sometimes we may take a biopsy from other site lesion, such as orbital fat, if it is involved, or other involvement. If we have to and we have no option, we can do it, and this is actually put on the mind for the last option.
Okay.
That's it.
Dr. Mazen, can you unmute yourself, please?
I'm sorry. Thank you very much, Athir, for your presentation. And now we will move to the fourth speaker, Dr. Majid Al-Bishari from Yemen. Dr. Majid, would you please start sharing your screen? Ustaz Dr. Isam Touhi and Dr. Muhammad Saeed Al-Himyari will discuss you. Dr. Majid, we can see your screen, but we cannot hear your voice.
Okay. Assalamu alaikum.
Wa alaikum assalam. Yeah, you can start. Bismillah.
Okay, I'll start. I am Majid Al-Bishari, resident ophthalmologist from Yemen. Tonight, I'll speak about using of interferon in treatment of ocular surface squamous neoplasia. Actually, it's a more recent topic and specific to interferon using of OSSN treatment. This is to announce that I have no financial disclosure or conflict of interest. Firstly, I'll answer the question, what is OSSN or ocular surface squamous neoplasia? Actually, it's an inclusive term that comprises a wide spectrum of conjunctival and corneal squamous tumor that may have a similar clinical findings but require biopsy for differentiation. OSSN may include many types, like CIN, neoplastic lesion of cornea, squamous cell carcinoma, and the mass malignant mucoepidermoid carcinoma. There are many morphological variants for OSSN, including nodular, papillary, gelatinous variant, placoid, nodulo-ulcerative, and also pigmented. All of those pictures are different variants of OSSN. We can diagnose OSSN, as mentioned previously by Dr. Zainab, by many methods, but the gold standard for diagnosis is the histopathology, and there are less invasive methods, including OCT, impression cytology, and ultrasound. Regarding OSSN treatment, we can segregate it into either medical or surgical treatment. I'll start by the surgical treatment. Surgical excision is gold standard for the management of OSSN, and the primary method of excision is no-touch technique with safe margin of about 4 millimeters during surgery. The medical treatment may include chemotherapies like 5-fluorouracil and mitomycin C and interferon alpha. Topical chemotherapy has been shown to be comparable to surgery with similar efficacy and recurrence rates. I'll start with the treatment of interferon and answer the question, what is interferons? What are interferons? Interferons are naturally occurring proteins produced by immune cells and have antiviral, antimicrobial, and antineoplastic properties that can enhance the phagocytic and cytotoxic mechanisms by human body. Why we choose and prefer interferon for treatment? Actually, it has many advantages, include the lowest side effects profile among other chemotherapies, and actually it has remarkably low recurrence rate ranging from only 0 to 5%. Moreover, interferon has antiviral activity that may play a role in anti-tumor effect of OSSN, since OSSN has been associated with human papillomavirus infection. There are many forms of interferon, including topical eye drops, subconjunctival injections, or we can use a combination of both. Both forms, topical and injections, are highly effective in treating OSSN with high rates of disease resolution of about 81 to 100%, and remarkably low recurrence rate of only, as mentioned, from 0 to 5%. Regarding eye drops, we can use the dose of 1 million international unit per milli Typically, medication is used 4 times a day until 1 more months after clinical resolution of the lesion. The average time for the clinical resolution is about 4 months using eye drops. Typical eye drops have the advantage of easy use and the minimal side effects. Injection form is about 3 million international per half a milli and are administered weekly until OSSN resolution, which typically require 4 to 5 injections to achieve the clinical resolution. It's about 1 month. Subconjunctival injection have the benefit of quicker resolution and assure compliance by the patients. Like any other medications, interferon also have side effects, but they are largely limited to mild irritation, conjunctival hyperemia, and follicular conjunctivitis. And those side effects resolve the continuation of treatment. And the main side effect of subconjunctival injection is the flu-like symptoms that last for about 2 days after administration of injection, but it's good that the side effect is resolved with administration of oral paracetamol. We know that the interferon is highly effective and has essentially no side effects, but it's an ideal choice for typical chemotherapy for OSSN, but actually it has the drawbacks, and its major drawback is the cost, as it can be more expensive than another chemotherapies. Additionally, it is becoming increasingly difficult to obtain, and it is not easy available in the pharmacies. Furthermore, the patient compliance is not ensured, as it must be used 4 times a day consistently until tumor resolution. Another drawback is that it must be stored in refrigerators at 2 to 8 degrees Celsius. Regarding the efficacy, many studies have looked at the use of interferon as a treatment of OSSN. And one study found that about 92% had complete of patients. Hello?
Yeah, we can hear you. You can go on, please.
Okay, about 92% had complete resolution with the treatment of interferon, and about only 8% didn't respond to the treatment with interferon. Also, studies found that the 1-year recurrences rates were similar to surgery, with about 3% in interferon groups and 5% in surgery groups. This is a picture of the patient with OSSN, which show the extension of tumor into the cornea, as we can see. This is the picture of for the same patient after topical treatment for 3 months, and it's clear and obvious the efficacy of interferon. Also, this is a picture of recurrent OSSN, including inferior pulpar and conjunctival furnaces. And again, it's the picture for the same patient after 3 months of intralesional interferon injections. And also with the follow-up of this lesion, there is no recurrence. This is the recent study and long-term of interferon eye drops as a primary treatment of OSSN. It's include about 143 patients, and its conclusion is that the topical interferon eye drops are safe and effective primary treatment modality for OSSN with reasonable side effects, which is good and great success. Also, there's another study for treatment outcome with interferon and OSSN. It's smaller than previous one, which include about only 27 patients, and its conclusion is that, in view of the excellent treatment outcome and few side effects, interferon can be considered as a primary, safe, and cost-effective treatment option for OSSN, not only in tertiary centers, but also by peripheral ophthalmologists. My conclusion is that several studies have demonstrated the efficacy, as we saw, and safety of interferon in treating of OSSN, particularly for cases where surgical intervention is not feasible or has failed with recurrences. Despite its limitations, interferon offers a non-invasive and effective alternative for management of OSSN, and its use should be considered in appropriate clinical setting. Those are my references, and thank you.
Thank you very much, Dr. Majid. And now we will open the discussion, starting with Ustaz Dr. Isam Al-Touhi, please.
Thank you. Shukran, Dr. Majid. This is a review of the literature. You are not presenting your cases. So at the end, even in your conclusion, you said that you'd use interferon in the appropriate clinical settings. Can you tell me when you will use it, when you will do the surgery, when you will use the mitomycin? Specific indications, in your opinion, based on your review of the literature, which patient should I use interferon in?
Yeah, actually, the gold standard treatment for OSSN, it's, as mentioned, it's a surgical excision. But in some cases, like large size, for about more than 4 o'clock of the OSSN, we start with interferon. Actually, as a chemo, we can use it as a chemo reduction before surgical excisions. And as mentioned, and as we said in the pictures, sometimes there is total resolving with interferon, but actually it's take longer than another chemotherapies. For eye drops interferon, it takes about 3 or more than 3 months for treatment.
Okay, so large as tumors as a form of chemo reduction. Any other indications for the interferon?
Yeah, sometimes the patient do not prefer the surgery, and after patient consultation, we can decide the treatment of interferon as the patient requested. This is another indication for interferon, but sometimes it's not easy available, especially in third world countries, so it's not always available.
Shukran.
Shukran, Ustaz Dr. Isam. But you are fine with the answer, Dr. Isam?
Yes, yes.
Okay. Dr. Muhammad Saeed Himyari.
Thank you, Dr. Majid, for this nice presentation. My question that you said that the gold standard for diagnosis of OSN is surgical excision. But we have the OCT, which is high specific and high sensitive. What do you think is better for the patient, and which one you prefer to choose?
You mean, I didn't understand. You mean which is better for diagnosis or for treatment between surgery and interferon?
Yeah, is it enough? Is it enough? I mean, in diagnosis of OSN, is it enough to do OCT, or you prefer to do surgical excision? As you mentioned, it is the golden standard in diagnosis.
Actually, by OCT, we can see the specific signs like thickening of epithelium and abrupt discontinuation of thickening of epithelium, which is pathognomonic signs for the OSSN. But actually, the main and the gold standard method for diagnosis is histopathology, which is preferred actually.
Thank you, Dr. Majid.
Fantastic. Thank you, Dr. Majid. Now we will move to the second hour, and we are moving smoothly, mashallah. Now, speaker number 5, Dr. Amal Abbas from Yemen as well. Now, you will be discussed with Ustaz Dr. Isam Al-Touhi and Ustaz Dr. Susan Qubtan. Are you with us? Dr. Amal, are you with us?
Yes, doctor. Do you hear me?
Yes. Please start sharing your screen.
Okay. Did you see?
Yeah, we can see. Yalla. You can start. Bismillah.
But it's not move.
Sorry?
Not move, doctor. Slides.
Is it the first slide? This is the first one?
Yeah.
Okay. I think it's from
Not
your
more,
computer.
not more.
Okay. Stop sharing and then reshare
I
again.
will repeat it.
Yes, please.
Okay.
Can you share?
Full
Yes.
screen or not full screen?
Yes, we can see it now.
It's not-
You can start sharing, please.
It's full screen?
No, it's not full
Okay.
screen. No, not full.
Okay. Just 1 second.
Dr. Mazen.
No, Dr. Tariq.
Yeah, ask a question.
Yes,
as
please.
regard the evaluation form, Dr. Isam have mentioned that the previous presentation was just a review of literature.
Yes.
So is there any points for being a work by the presenter, or it doesn't matter whether it is a work by himself or a review? Because the evaluation form has no point to evaluate this point. So I want to ask.
No problem, no problem. Whether it is case report, a new idea, new research, a review of literature, no problem, inshallah. Thank you for this question. Dr. Aman?
Yes. That is Abir?
Yes.
But it's
You
not
can
more.
start.
Yes, it's okay.
But, okay, but slide not more.
Doesn't move, you mean?
I don't know why. Yes, yes.
You can
You put the mouse on the slide and
Okay,
yes,
okay.
that's it. Yeah, very good.
Okay. Good evening to everyone. I would like to thank Dr. Mazen Sinjab for giving me this opportunity to share my presentation with you. I am Amal Abdul Wahid. I'm from Yemen. I have a Yemen burden of ophthalmology. My presentation today about the management of the orbital lymphangioma using intravaginal injection of the bleomycin. I will start with the case presentation. This is case, it's 8-year-old male, visited our clinic, clinic complaining of the upper eyelid swelling in his right eye for 6 months. And this swelling was not associated with the decreased vision, diplopia, redness, or discharge. And there was no history of the trauma. By examination, there was LD1 supermedial orbital mass, no tenderness or no pulsation or thrill, and no preorbital change, and no change in the size with the change in the position or within the vasalava. The CT scan was done to this patient that show about 5 by 2 millimeter L-defined macrocystic mass that diagnosed as orbital lymphangioma, and advised the patient for observation. 6 months later, the patient complained of the sudden onset of proptosis, progressive for 3 days, redness, pain, swelling of the eyelid, and decreased vision. By examination, the visual acuity was 6/60 in OD and 6/6 in OS within the superior medial orbital L-defined mass, about 2 cm by 1 cm that cause non-axial proptosis inferior lateral. This is mass is soft impalpation with no tenderness and no pulsatile. The rest of the ocular examination was within the normal limits, including the ocular motility in all gazes, and the examination of the left eye was normal. By Hertel exophthalmometry with 100 millimeter base was 21 millimeter in the right eye and 17 millimeter in the left eye. The CT scan was repeated and that showed about 22 by 24 millimeter infiltrated and diffused mass in the intracorneal and extracorneal space of the right orbit, and also diagnosed as the orbital lymphangioma, and prepared the patient for aspiration under general anesthesia. Under general anesthesia, 12 cc of the blood was aspirated. 4 days later, 4 days later of the aspiration, the patient was complaining of the severe pain, tenderness, chemosis, proptosis that was 26 millimeter by Hertel, and start to complain exposure keratopathy, limitation of the extraocular movement. The patient came to Dr. Tariq Al-Duais, and Dr. Tariq done aspiration again under general anesthesia, and I was with him. We aspirate about 12 cc of the blood, but no within bleomycin injection. We inject about 1 international unit per milliliter saline into the cystic wall in multiple puncture. 1 month of the follow-up, the patient's clinical features were completely resolved, and the CT scan showed no residual macrocystic lymphangioma and no signs of the rebleeding, no signs of the recurrence 6 months later. Now I will talk about the orbital lymphatic malformation that was previously known as the lymphangioma. This is malformation are hemodynamically isolated vascular hematoma that arise from the venous system embryologically and have differentiate in part or whole to the lymphatic vessels. They are present at the birth and are composed of the abnormal and dilated locks of the lymphatic tissue that result from defect embryologic development of the primordial lymphatic channel. This cystic lesion are characterized by abnormal endothelial lined lymphatic cysts, which vary in the size from few millimeter to several centimeters. The lymphatic malformation represents about 1 to 4% of all orbital masses. Radiographically, the lymphatic malformation are classified into macrocystic, in which the cyst is more than 2 centimeters, which are large cysts that can be seen in the orbital imaging and when display fluid level when the patient is supine. They are common found in the intraconal space and are typically more stable than the macrocystic lesion, which are more prone to the recurrent hemorrhage. Macrocystic, the cyst was less than 2 cm, which are solid and infiltrative lesion and usually found anteriorly. And there are mixed type that have macrocystic and macrocystic. Orbital lymphangioма, clinical features of the orbital lymphangioma, it can be asymptomatic. However, the symptoms might appear as slowly as orbital mass or suddenly hemorrhage of the lesion, causing painful proptosis, compressive optic neuropathy, exposure keratopathy, increased intraocular pressure, and restrictive ocular motility, and decreased vision. These symptoms might appear after upper respiratory tract infection or minor trauma. Diagnosis of the lymphatic malformation, it was clinically and by the imaging studies like CT scan or MRI, which is demonstrate either deep cyst within the rim enhancement or solid lesion within the cystic component that can be detected by MRI. Management of the orbital lymphatic malformation is within the observation and simple aspiration of the anterior cystic component, and the intervention was indicated if there is acute orbital hemorrhage, progression, or significant cosmetic disfigurement. The surgery can be challenging because the lymphatic malformation, it is unencapsulated in nature, which is interdigitate within the surrounding normal vital structure in the orbit. Also, the complete resection of the lymphatic malformation is difficult, so this disease is more prone to recurrent. Other modalities of the treatment include radiotherapy, intralesional or oral corticosteroid, or intralesional sclerosing therapy. Intralesional sclerosing therapy, it's used to induce cyst collapse by distorting the epithelial lining of the cystic wall of the macrocystic lymphangioma and by reducing the lymphatic fluid production. The options for sclerosing include absolute alcohol, bleomycin A5, sodium morate 5%, sodium tetradecyl solvate 3%, and bengamycin and doxycycline. My presentation about the bleomycin, I will talk about the bleomycin. The bleomycin is a chemotherapeutic agent that is commercially available in the dried powder form in the vial containing 15 international units of the bleomycin, and every 1 unit of the bleomycin, it is equivalent to 1 milligram, and the
Hello. Hello?
At that time, أيوة.
Repeat, please. Your voice disappeared for just 5 seconds. If you can repeat what you were saying in this slide.
Okay, the bleomycin is a chemotherapeutic agent that is commercially available in the dried powder vial containing about 15 international units of the bleomycin, and every 1 unit of the bleomycin is equivalent to 1 milligram. The required dose that was calculated as 0.5 milligram per kg of body weight, and the dose should be not exceeding 10 units at time. And this is injection, it used is taken in the OT, and the fluid of the lymphangioма was aspirated as much as possible. After that, the bleomycin was injected intralesionally in the ratio of 5 to 1 to 1 of the aspirated volume to the bleomycin volume. And the care should be taken when to keep the needle outside the muscle cone. Also, after the injection, we should apply local pressure to prevent leakage of the bleomycin. The patient should be kept under observation and the same day of the injection and after 4 weeks. But if the regression was not complete, another dose of the bleomycin was injected in the same manner. The treatment is discontinued after maximum 3 injections or when no further signs of the resolution was noticed clinically. The patient should be also remained under follow-up for 6 months after completion of the treatment course. Side effects of the bleomycin include eyelid edema, transient increase in proptosis, diffuse subconjunctival hemorrhage, erythema, pain, and hypopigmentation, and local skin necrosis and flu-like symptoms. And no systemic complication was reported in the intralesional injection of the bleomycin. So my home message is the orbital lymphangioma is a rare but benign tumor that is arise from the lymphatic system in the orbit, and sclerotherapy is a safe and highly effective in treatment for the orbital lymphatic malformation with excellent visual acuity outcome, and should be considered the first line of the treatment for this condition. This is my reference, and thank you.
Thank you very much. Now we will open the discussion. Ustaz Dr. Isam Al-Touhi, please.
Thank you, Dr. Amal. I just need you to tell us the technique of aspiration. Was it ultrasound guided, for example? And you can also explain what happened after the first aspiration and how this was avoided in your second aspiration. Give me the explanation, what happened in the first one and what did you do differently so that it didn't occur in your second aspiration, please.
Okay. Firstly, doctor, aspiration we used under the guided of ultrasound or CT scan, but in our case, we will not use the CT scan or MR or ultrasound guidance. Why there is no why the hemorrhage is happened in the firstly and then not happened in the second aspiration? And the first aspiration, this is not done by us. This is done by another doctor, and then the patient referred to us. But I think because there is a rupture of the venous and there is a hemorrhage or maybe like this. I don't know what happened for this case.
What do you think happened, and how would you avoid this so it does not happen again? What did you do differently?
I think to do the aspiration under guidance or ultrasound or CT scan, maybe it is help us to confirm we enter the needle or aspiration needle to the cyst, not the maybe like this.
How far would you go with your needle aspiration?
What's your question, doctor, please?
How far posterior would you go?
For this cases or in general?
In your case, at least.
Doctor, I don't remember really.
اوكي. اهلا دكتوره سوزان، اتفضلي يا فندم.
دكتور
مرحبا
سوزان.
دكتورة طه، كيف الصحة؟ إن شاء الله بخير. دكتورة أمل، nice presentation و nice subject. عندي سؤال واحد. He is 8 years old boy و presented with a swelling over the upper lid. At the start you did for him MRI or CT? الإيروإيميجينج كان
For this
CT
patient,
ولا MRI؟
لا
عملتوا له
CT scan.
بالبداية أول برزنتيشن قبل البروبتوسيس لما كان مجرد عنده ليد سويلينج، عملتوا له MRI and CT ولا خليتوه من بعد
Just
الست
CT.
شهور؟ فقط
لا just
CT.
the first just CT.
just CT. وكان من السيتي من
Yeah.
الأول مرة واضح إنه عنده ليمفانجيوما.
Yeah, he is diagnosed by radiologist as the lymphangioma.
طيب. يعني ما خليتوا في بالكم احتمال إنه يكون رhabdomyosarcoma؟
From
الإيج
clinically,
مالته
there is
يساعد.
maybe the age, but the clinical features of our history and examination, it is not come with the rhabdomyosarcoma.
طيب على المرة الثانية من حضر بعد 6 شهور وسيفير بروبتوسيس وكان عنده بادي يعني الديستوبيا، صح؟ الست
Yes.
شهور هذه اللي بين التو برزنتيشن you followed him or he disappeared?
He disappeared and so he come with this when the proptosis is progressive.
The usual story بالمريض العربي. شكرا.
شكرا دكتورة سوزان. شكرا أستاذ دكتور عصام. Thank you Amal. Now we will move to the sixth speaker, Dr. Ihab Ali from Yemen, and the discussion will be with Ustaz Dr. Sumaya Al-Hanafi and Dr. Muhammad Saeed Al-Himyari. Are you with us?
Yes.
Please start sharing your screen.
I can share my screen, Doctor. Who's disabled participant screen sharing?
It is.
Okay.
It is
okay,
able.
now I can share. Yes. Good evening, everyone. My name is Rahab Ali Saleh, ophthalmology resident, third year. I'm here. I will speak today about orbital lymphoma. Thank you for having me. Let's start with the case report. This is a 9-year-old female presented to the hospital with superior orbital mass, which was gradual and progressive, ill-defined, hard inconsistency. She had a 1-month history of anorexia, 10 days history of fever and painful eye. No history of any systemic disease, no history of similar family history. On clinical examination, the VA was 2050 OD, 2020 OS, the IOB with a normal range, extraocular muscle intact, no diplopia, anterior and posterior segment with a normal. There was a proptosis, which measured in the right eye 22 millimeter, left eye 17 millimeter, non-pulsatile. There was dystopia, finally regional lymph node enlargement. On the investigation, MRI, the mass is slightly hypointense to extraocular muscles on T1, slightly hyperintense on T2. Identify the lateral rectus muscles which pushed inferiorly. There is homogeneous enhancement with gladiolin contrast in administration. On CT, orbital soft tissue mass isodense to extraocular muscles with microptosis and medial diffusion of the orbit and optic nerve. Finally, laboratory study showed normal complete blood count. Differential diagnosis according to the age of the patient and the clinical presentation, we think about rhabdomyosarcoma, cavernous hemangioma, orbital lymphoma. The patient underwent anterior orbitotomy and excisional biopsy was done and searched for histopathology. The histopathology report was extranodal marginal zone lymphoma with dominance of CD20, CD79A, PAX5, expressing B lymphoid cells. So the diagnosis goes with orbital lymphoma. The patient further received chemotherapy consisting of cyclophosphamide, adriamycin, vincristine with the oncologist. 6 months after, the patient has improved. Let's talk about orbital lymphoma, simply lymphoproliferative tumor of ocular adnexia consisting wide spectrum of the lesions that range from reactive benign hyperplasia to malignant lymphoma. Ocular adnexal lymphoma is a localized form of systemic lymphoma affecting orbit, lacrimal gland, eyelid, and conjunctiva. It comprises from 6 to 8% of the orbital tumor, from 10 to 15% of adnexal lesions. Ocular adnexal lymphoma considered primary if involved ocular adnexa alone, and secondary if accompanied by lymphoma of identical type at another site. The majority of the lesions in this area are non-Hodgkin lymphoma. 80% arise from B lymphocyte, 14% from T cells, only 6% from natural killer cells. The most common primary ocular adnexal lymphoma is low-grade malignant extranodal marginal zone B cell lymphoma of mucosa associated lymphoid tissue. Other types include follicular lymphoma, diffuse large B cells lymphoma, mantle cell lymphoma, and lymphoplastic lymphoma. And this picture is for follicular lymphoma. Secondary orbital lymphoma arise from systemic disease and are represented by intermediate or high-grade follicular lymphoma. In those presenting with orbital lymphoma alone, systemic lymphoma eventually developed in 1/3 of the patient by 10 years, whereas only 5% of the patients with non-Hodgkin lymphoma developed ocular adnexa involvement during the course of their disease. The grading and the staging is throughout an Ann Arbor system. Low grade, indolent or slow grade, intermediate, moderate grade, high grade, aggressive or rapid growth rate. Staging, stage 1 confined to the orbit, stage 2 involved into a Janus structure such as sinus, tonsil, or nose. Stage 3, abdominal nodal disease below the diaphragm. Stage 4, disseminated involvement of one or more extranodal sites such as liver or bone. There is no clear risk factor about orbital lymphoma. There are a combination of increasing age, immunosuppression, AIDS patient, multiple infection like chronic chlamydia, herpes viruses, toxoplasma, or H. pylori, chronic autoimmune disease like systemic lupus erythematosus or rheumatoid arthritis, and inflammatory disorder like Sjogren's syndrome. Management. The radiation is the most frequently used modality for treating ocular adnexal lymphoma. It's depending on the site, extent of the disease, and tumor grade or type. Recurrence of the low-grade types are often treatable with the local modalities. The chemotherapy, systemic chemotherapy, is not routinely indicated for solitary ocular adnexal lymphoma except in the presence of diffuse large B-cell lymphoma, and for part of the stage 2 or greater chemotherapy has induced use in the standard regimen for systemic lymphoma. Anti-lymphocytic antibody represent the newest form of lymphoma treatment medication called rituximab using antibody to CD20. Typically, surgery is performed to obtain adequate specimen for the biopsy and histopathological evaluation. Complete excision is usually not indicated nor performed and can risk injury for the vital structure, for the orbital structure, sorry. The follow-ups, it's suggested that visits should be occur once every 3 months for 2 years, once every 6 months for 3 years, annually after that with the close coordination with the oncologist and radiation oncologist if involved. The prognosis is generally good. Ocular adnexal lymphoma, developing systemic lymphoma after 4 years, most commonly eyelid, orbital, then conjunctiva. My conclusion, orbital lymphoma is rare and represent around from 1 to 2% of the lymphoma, about 8% of extranodal lymphoma. It's usually asymptomatic depending on the location of the mass. Patient can complain of exophthalmos pain or diplopia. Diagnosis is typically made through a combination of the clinical imaging study and biopsy. Treatment options include radiation therapy, chemotherapy, and surgery. Prognosis generally good with rate remission and long survival term. Close monitoring and follow-up are important to decrease the recurrence rate. Thanks for your attention, and these are my references.
Thank you very much. I open the discussion now. الأستاذة الدكتورة سمية حنفي.
Okay, thank you, Dr. Rihab, for your presentation. I have a question here. In your case, you have confined orbital lymphoma to the orbit only. So why you prefer to start patient on chemo? And And did you do metastatic workup in this case? To rule
Can I
out?
answer now?
Yes, sure.
Because my case, it's according to the stage 2, according to the stage of the orbital lymphoma. So we start the chemotherapy with the oncologist, and the follow-up was with the oncologist.
Okay, and did you do metastatic workup in this case? Metastasis workup?
I
As
didn't
a
get
PAN or PAN-CT? Did you do metastatic workup for this patient to
No.
rule out metastasis? No. Thank you, Doctor.
Okay.
Dr. Mohammed Saeed Hamiri.
Thank you, Dr. Rahab, for this nice presentation.
You're welcome.
Actually, I have 2 questions for you. First questions, you said this patient has dystopia. And at the same time, you said you are using or you used Hertel exophthalmometer. Can we use axial or Hertel exophthalmometer in non-axial proptosis? This is my first question. My second one, you said in your conclusion that complete excision of the lymphoma is not indicated as you are going to destruct the orbital structures or the fatal structures in the orbit. But at the same time, you said you did excisional biopsy. So how come?
We did for the first, sorry, what was the first questions?
Can we use Hertel exophthalmometer
Yes,
in
we
non-axial
can use.
proptosis? I will leave Dr. Sumaya to answer this question. Can we use it, Sumaya, for dystopia, Hertel?
Yes, doctor, we can use the Hertel for axial. You can measure both axial and you
No, I
can
mean,
a ruler for also displacement. You measure the inferior or lateral displacement. You can use both.
but
Because
the
we have
proptosis we
combined
can use.
axial, yeah, axial and non-axial. It's combined here. Yeah.
Okay, and second question?
About the second questions, we do incisional biopsy. And the,
You said excisional.
sorry. But the surgery, it's for incisional biopsy. You can do complete excision because you will do injury for the vital structure, orbital vital structure, adjacent structure.
Thank you, Dr. Rahab.
Welcome. Thank you.
So was it by mistake said or it was mentioned in the slide as excisional?
Can I see my slide, please?
No need to share. You can check it and let us know because still we have time.
It's by mistake. I write excisional biopsy and I tell excisional biopsy.
From here came the
But
conclusion.
it's incisional biopsy.
All right. Thank you very much.
All the best, Dr. Rahab, all the best.
Yes.
Thank you.
If we have time,
yes,
I just need
Dr.
to add here that we usually go in with the intention of complete excision of any orbital mass, actually. Okay. During surgery, when it is clear that the mass is mostly malignant, usually with the texture, particularly with the lymphoma, you know that this is a lymphoma, a type of the tissue, then you stop going further or digging to get the whole tumor. يعني تكتفي باللي تقدر تاخده بدون التعمق او الجري ورا كل سيل او كل اريا علشان ما نعملش اللي الدكتوره رحاب قالته. لكن الايم في البدايه is always to remove all وثم القرار بيختلف intraoperatively الحقيقه في احوال كتير.
Thank you very much, Dr. Isam. Now we will move to the seventh speaker, Dr. Noor Ahmed from Yemen as well. The discussion will be with Ustaz Dr. Mahmoud Shtewi and Dr. Tariq Al-Tais. Would you please start sharing your screen?
Assalamu alaikum.
Alaikum salam.
Can you listen me clear?
Yes.
Thank you. Okay, I will share my screen now. Is it clear?
Yes.
Okay. Good evening. It is an honor to share with you my case. I am grateful for Dr. Mazen Sinjab and Sinjab Academy for this opportunity. I am Dr. Noor Ahmed, a general practitioner, and I have Arab and Yemeni board certification. So let's start the case of periorbital necrotizing fasciitis. Starting with the history, a 65-year-old male patient presented to the outpatient clinic in June 2019, complaining of swollen black eyelid skin with minimal pain for 3 days. He was on chemotherapy for lymphoma, and he denied any trauma. The general examination of the patient was very normal. He looked stable and with a beautiful smile on his face. The vital signs were all normal except of mild fever, but the left upper and lower eyelids and cheek were swollen with an inability to open the left eye. There was a circumferential black necrotic eschar and ulceration. And unfortunately, at this moment, we cannot assess the condition of the left eye. The patient was very poor and already exhausted from chemotherapy, doing a lot of investigations and previous imaging. So the clinical diagnosis of necrotizing fasciitis is established and urgent action was decided. Immediate debridement of necrotic tissue and application of local fusidic acid ointment was done, and a combination of amoxicillin plus clavulanic acid with metronidazole was given systemically. Then we follow the patient daily with debridement if needed, and application of local and systemic treatment was done. After 1 week of daily follow-up, there was an improvement in swelling and healing was progressive, and finally we saw the eye of the patient. Then with re-examination, we found that the eye was quiet, no redness or proptosis. The visual acuity was 6.9 in both eyes. There is no relative apparent pupillary defect, and the cornea was clear, transparent, with no ulceration. And the fundi with extraocular muscle were normal without any limitation of movement. Let's go on a fast review of the periorbital necrotizing fasciitis, which is a rare, rapidly progressive soft tissue infection characterized by cutaneous gangrene and vascular thrombosis. The cervicofacial area is rarely involved in this rare disease. And in this study by the campus, that the first necrotizing fasciitis cases was reported early in 1959. It is usually polymicrobial, but group A beta hemolytic streptococcus is the most common causative organism, being responsible for 50% of cases. And usually it's 2 types, polymicrobial that affect immunocompromised and monomicrobial that affect immunocompetent. So the risk factors for developing necrotizing fasciitis, usually local or systemic infection, trauma that is sometimes trivial, so the patient cannot remember, and immunosuppression, but sometimes it will affect immunocompetent also. When we diagnose necrotizing fasciitis, is usually clinically by pain that is disproportionate to physical examination, but it's not mandatory to present in all cases. The patient will complaining of red swollen periorbital skin, usually febrile and immunosuppressed, having any risk factors. Then villus ulceration and black necrotic eschar will form rapidly and progress within days. The ocular examination of the patient should include visual acuity and relative apparent pupillary defect to exclude optic nerve involvement. And a slit lamp examination for corneal affection by proptosis if present and exposure keratopathy. And if the proptosis is present, we should measure it and follow it. So in diagnosing necrotizing fasciitis, should CT or MRI done? And could they differentiate necrotizing fasciitis from cellulitis. So this is an axial CT scan demonstrating extensive periocular soft tissue thickening and air bubble anterior to the globe. And the air bubbles anterior to the globe is pathognomonic for necrotizing fasciitis. But 50% of cases that is not streptococcal, that is not caused by an anaerobic organism, could be without gas. So a study of necrotizing fasciitis and its mimics conclude that imaging can reveal non-specific or negative finding. So CT scan or MRI cannot differentiate between necrotizing fasciitis and other soft tissue infection. But if we can choose between them, CT scan is preferred as it has high sensitivity and it also faster in a setting of emergency cases. There is another laboratory investigation that helped to differentiate advanced soft tissue infection from necrotizing fasciitis. Called laboratory risk indicator for diagnosis of necrotizing fasciitis include C-reactive protein, WBC, hemoglobin, sodium, creatinine, and glucose. And if the patient has a score of 6 or more, necrotizing fasciitis should be suspected. So what's the differential diagnosis? Could be orbital cellulitis, periorbital cellulitis, vasculititis of any types, such as Wegener granulomatosis, sarcoidosis, neoplasm, such as lymphoma, leukemia, and trauma. So in management, early recognition and initiation of high dose of antibiotic combined with tissue debridement is essential and associated with lower mortality. Surgical debridement of affected tissue increases the effectiveness of antibiotic penetration. A combination of beta-lactam antibiotic and amine glycosides is the first line of therapy, and then after the patient stabilized, reconstructive surgery can be planned for later date. The possible complication could be site-threatening complications such as optic neuropathy, retinal vein occlusion, severe exposure keratopathy, or life-threatening complications such as cavernous sinus thrombosis, meningitis, and death that present in 10% of cases. And in this study that called eyelid necrosis and periorbital necrotizing fasciitis reported that the death from upper part of the head and the affection of upper part of the face and the scalp bring a better prognosis than the affection of lower head and neck. The death rate reached to 30 to 70% in other part of the body. Our patient was a patient and providential person. His journey of healing was a real magic. I would thank Allah, it's all his favor, and I would thank also my colleague, Dr. Noor Shobaki, for being part of this happy story. My take-home message is that periorbital necrotizing fasciitis is a devastating fatal disease, but early recognition can save the life of the patient. And the typical presentation is not typical for each patient. Every clue should be taken seriously in any patient who has any risk factor. And adherence to treatment, even if it is simple, as in our case, it's just simple antibiotics, can give impressive results. And this is done through commitment between doctor and patient. And before that, trust and believe that Allah is the healer. Thank you so much for your time and attention. And those are my references.
Thank you very much. Now we open the discussion. Ustaz Dr. Mahmoud Shtewi.
Okay, thank you, Dr. Mohab. It was very excellent presentation. So good. But I have two comments about you say you have Arab board or something like that, and you said I'm a GP. Are you a GP or a specialist now?
General ophthalmologist, senior ophthalmologist.
Yeah, because you said GP, that's why I hear that.
Oh, maybe it's my fault.
Okay.
Sorry.
Yeah, and you said the first diagnosis of periorbital necrotizing fasciitis is 1999. I think it's before that.
20.
Being reported. Mm-hmm. You said 1999. The first diagnosis of
1952. Oh, sorry, 1952. Yes.
Yeah, you see, this is completely, yeah, that's right, that it's by mistake or something like that.
Yes.
And yeah, other than that, I don't think you did very well from my side.
Thank you so much.
My experience. Okay, good luck.
Thank you so much.
شكرا أستاذ دكتور محمود. أستاذ دكتور طارق الدايس. We cannot hear you.
Thank you, Dr. Anor, for this nice presentation. I would like to ask you about how can you differentiate fasciitis from other infectious disease in the orbit? And why cannot send him for a CT scan to see the advanced disease and extent of the orbital lesion?
Thank you, Dr. Tariq. The answer for the first question, that how can we differentiate necrotizing fasciitis from other inflammatory disease? There is some clues in clinical symptoms and sign. The patient usually immunosuppressed and has a risk factors. There is sometimes trivial trauma, and he come for rapid progression of pain, redness, and then by examination we saw the black change, the blistering, the skin change that is specific for necrotizing fasciitis. Then there is some investigation such as CT scan that detect the air, which is pathognomonic in necrotizing fasciitis, but unfortunately it is just for 50% of cases who has a polymicrobial and anaerobic infection. For the second question, why we did not send the patient for doing CT scan, because the patient was already diagnosed as lymphoma and did a lot of investigation and imaging. We reach to the diagnosis clinically and see there is excellent improvement in his by the treatment empirically with antibiotic, and then we decide to follow him clinically. If there is any worsening, we then send him for imaging. But in this case, with the excellent improvement, we chose to not getting more radiation risk for this patient because he already a survival of cancer.
Okay, thank you.
Thank you.
Thank you very much. That's great. Now we move to the last speaker.
Thank you so much.
Yeah, you are welcome. Dr. Wajdan, you are with us?
Yes.
Dr. Wajdan Al-Mutawakkil from Yemen?
Yes.
Yes. You will be discussed by Ustaz Dr. Siham Shariba and Ustaz Dr. Isam Touhi.
Okay.
So
I'm going to share my screen. Let me know when it is shared, please.
Okay. Yes, we can see the screen now.
Okay, I'm going to start.
Bismillah.
Thank everyone, and thank you for joining. My name is Dr. Wajdan Al-Mutawakkil from Yemen, resident ophthalmologist. I'm pleased to discuss the subject of TIPIZA and treatment of thyroid eye disease. I will start talking about thyroid eye disease in brief, and then I will start my main topic. It's the most common cause of both bilateral and unilateral proptosis in adults. Women are 6 times more likely than men. Smoking is strongly associated with severity and the risk of the disease. Age, according to the first and second week, in the 3rd to 4th decades of life, and in the mid-60s. The pathogenesis of ophthalmopathy, it's not fully known, but insulin-like growth factor 1 receptor overexpression and activation with orbital fibroblasts, which has a CD40 marker. The T cells bind to this marker and upregulates fibroblasts leading to inflammation of the extraocular muscles, interstitial tissues, orbital fat, and lacrimal glands characterized by polymorphic cellular infiltration and increased secretion of glycans. The volume of the orbital contents increases. The muscles can swell to 8 times their normal size. There may be a secondary elevation in the intraorbital pressure and optic nerve compression. According to muscle fibers, there is a degeneration leading to a fibrosis resulting in restrictive myopathy and diplopia. Here are the clinical features. There are the early and the late ones. The early orbital pain and discomfort, redness, tearing, photophobia, morning puffiness of the eyelids. The late ones are the lateral flare, prominent eyes, persistent eyelid swelling, chemosis, double vision, pressure behind the eyes, and decreased vision. The most common sign is eyelid retraction, characteristic temporal flare of the upper eyelid, eyelid lag on down gaze. If the extraocular muscles are involved, elevation and abduction restricted. About the management, we have general management, medical and surgical ones. The general are smoking cessation, refer the patient to an endocrinologist, treat exposure keratopathy with lubrications, and treat eyelid edema. The medical management, prednisone 1 milligrams per kg daily, tapered over 4 to 6 weeks. The surgical management, orbital decompression surgery, if optic neuropathy, worsening or severe exposure keratopathy despite adequate treatment, a globe luxation, uncontrollably high intraocular pressure, morbid proptosis, and strabismus surgery, eyelid surgery. Here is the main topic about the TEPEZA. The mechanism of action is not fully known, but it is targeted biological inhibitor of insulin-like growth factor 1 receptor. It helps to decrease proptosis and diplopia. In the USA, the price is between $14,900 to $16,300 per vial. I'm going to share with you a video showing how TEPEZA works to treat thyroid eye disease.
How TEPEZA works to treat thyroid eye disease, or TED. Thyroid eye disease, or TED, is a serious vision-threatening condition. You may have heard thyroid eye disease called Graves' eye disease. To understand what causes TED, you have to go behind the eye. In the tissue behind the eye are cells which have receptors on their surface that act like switches. But when you have TED, your body's immune system attacks this tissue, which causes molecules, known as autoantibodies, to turn these switches on. This leads to swelling of the muscle and fat. This swelling can cause a number of symptoms like eye pain, redness in and around your eyes, and swollen eyelids. The swollen muscle and fat tissue behind the eye can also make the eyes bulge, which your doctor may call proptosis, and cause double vision, which your doctor may call diplopia. TEPEZA is the first and only FDA-approved treatment for thyroid eye disease. Unlike other medicines, TEPEZA treats the cause of TED, not just the symptoms. TEPEZA is designed to bind to the switch and block it from turning on. Since TEPEZA blocks the switches, so they cannot turn on, swelling of the muscle and fat tissue goes down. This leads to reduced bulging and less redness, pain, and swelling of the eyes. TEPEZA can also improve double vision and, in some cases, make it completely go away. TEPEZA has also been proven to improve visual ability and physical appearance. So ask your doctor if TEPEZA is right for you.
Okay, it's the use of TEPEZA. It's IV infusion 10 milligrams per kg, followed by maintenance infusions 20 milligrams per kg every 3 weeks. In this schedule, it shows that the treatment of TEPEZA is 8 infusions. Each infusion is taken once every 3 weeks. The first and the second infusion will take 90 minutes each, and then the rest 6 infusions will take 60 minutes each. The total course of the TEPEZA is 5 months. Here's the infusion reaction. It can happen during or within 24 hours. High blood pressure, fast heartbeat, redness of face, feeling hot, difficulty of breathing, headache, muscle pain, worsening inflammatory bowel disease, increase in blood sugar. So keep in mind, before giving TEPEZA, ask about inflammatory bowel disease, diabetes, pregnant or planning to become pregnant, breastfeeding, and medication use. Here is the side effects: muscle cramps and spasm, hair loss, weight loss, headache, hearing problems, changes in taste, dry skin, feeling tired, increase in blood sugar, nail problems, and changes in menses. When does the improvement occur of TEPEZA? Actually, TEPEZA works quickly. Some people began to see less eye bulging, redness, and swelling as soon as 6 weeks. That means after the 2 treatments. But to get the full benefit, they should take the 8 infusions. This picture of a female which had a previous surgery, thyroidectomy, and she had many treatments was taken, but after the treatment, the improvement is obvious here. About this, the course, is one course of treatment enough? Another course of treatment might be needed to treat disease flare in some patients. Among the trials about the sex, race, and age, it's similar effect in men and women. The majority of patients were white, similarly in patients above and below 65 years of age. Here are the clinical trials. As I mentioned before, that it works quickly. And as we can see here at this graph, that it starts from the beginning, but the improvement was at week 24. Here is 2 different pictures of 2 different patients, one without teprotumumab and the second with teprotumumab, and it's obvious how the improvement occurred with teprotumumab group. About 67% of patients who were diplopia responders at week 24 maintained a response at week 72. They had little to no signs or symptoms of inflammation. About the functional vision, it improved the functional vision, and the patient was able to perform daily activities, and it improved the appearance of the patient. My conclusion is that the FDA approved TEPEZA for treating individuals with thyroid eye disease. More than 8 out of 10 patients who completed all the 8 infusions of TEPEZA had less eye bulging. 7 out of 10 had improvements in double vision. Patients also had less eye redness, pain, and swelling. Thank you for your attention, and if you have any questions, I'm glad to answer them.
Fantastic. Thank you very much. And now we open the discussion. الأستاذة الدكتورة سهام شاربة.
Thank you. And thank you, Dr. Wigden, for this presentation. I have 2 questions. First, what is the place of mycophenolate CellCept in association with corticosteroid before the expensive TEPEZA? And the second question is, there's a lot of secondary effects of TEPEZA. What about the place of multidisciplinary care? Thank you.
I did not understand about the first. Can you repeat the first question, please? And the second, do you mean the place where this trials happened, or?
TEPEZA is second line of treatment before we give corticosteroid, and we can add CellCept. Mycophenolate. Do you know? Do you know this association?
No, I really don't know about this thing.
So what's the place of multidisciplinary care?
I did not get your question.
What do you think about it?
About what?
Multidisciplinary care. You don't understand?
Yes, I cannot pick you.
multidisciplinary care يعني التعاون مع دكتور الاندوكراينولوجي، دكتور الباطني، دكتور السكر.
Yes, yes, it is with the treatment of TIPIZA and any it's an autoimmune disease, so we need to this disease have to share with many specialists. I think I answered your question good, or
that's it. That's it. It's okay.
Thank you.
Thank you, Ustaz Dr. Isam.
Okay. Let me phrase Dr. Seham's first question, because this is, again, is my question. What you have been showing is كله is a comparison between TIPIZA and placebo.
Yes.
Okay? Even all the studies you are showing is comparing TIPIZA against placebo. When we compare any drug against placebo, we are actually comparing the drug against the natural history of the disease. We want, particularly if we are FDA or if we are the authority approving a drug, we need to prove that this drug will not be more harmful than the natural history of the disease. And TIPIZA showed that it is not more harmful than the natural history of the disease, and this is good. But to use it as a treatment, we need now to compare it against what we are usually using now, which is steroids. In all your presentation, you did not compare between the use of the new drug TIPIZA versus our old established regime of steroids, whether these steroids were taken systemically, were given intraorbitally, it doesn't matter. But we need a reply about TIPIZA versus the steroids, particularly if you are saying, and we all know, that the one vial of TIPIZA is $15,000 and the patient needs between 8 to 10 vials of TIPIZA. So you are talking about $250,000 per patient.
Yes,
okay?
but yes.
What do you know about TIPIZA versus what we have now, the steroids?
Okay, with the trials that I read about, that the patients were unsatisfied with their results, and they did so many surgeries, and they took steroids, and they did everything. So if they take TIPIZA according to the CAS score, which is more than 4, TIPIZA works quickly, and they were satisfied, too much satisfied.
Versus the steroids.
Yes.
Okay. Dr. Seham, do you have any comments?
There is conflicts of interest with the TIPIZA.
Okay. Thank you, Dr. Wigden.
You're most welcome.
Thank you very much. There is a question for you, Doctor. Does TIPIZA has a role in the treatment of pseudotumors?
Well, for pseudotumors, it's not TIPIZA. It's not a chemotherapy. They are all given as IV infusions, but it's not at the same as a medical subsequent. Yes.
Okay, fantastic. Now, there is a question to the first speaker, Zainab, from the audience as well. Zainab, you are with us, correct? Zainab? Zainab bin Saeed, you are with us? Okay. So, at the end of this session, I'd like to take the pleasure to thank the panelists for devoting their valuable time to support the mission of the program. Indeed, the panelists are the ones who deserve thanking rather than me or Sinjab Academy. Indeed, I cannot hide my surprise with the high quality of the speakers and the presentations. Hats off to your teachers and to your efforts. We are sure you have a brilliant future, and you will be the best ambassadors carrying the mission of loving, of giving. وتذكروا أن زكاة العلم التعليم. Thank you very much, and I would like to hear from the panelists if they would like to add anything.
لو سمحت دكتور مازن.
دكتور محمود تفضل.
طب احنا نتكلم كبانلست ولا ما زال الكانديديت with us؟ ولا they finish؟
هلا
عندي شوية كومنت
خلاص
they already gone يعني.
Of course, there are audience as well. So for the comments between us, better to have another Zoom meeting.
Yeah, that's why I need to talk to you about it. That's why I said.
Yes, inshallah. We will do another Zoom meeting, inshallah.
Please, if you allow me, I'd like to thank you very much. It was a big pleasure. I can't tell how a big fan I am for Dr. Sinjab, Dr. Tariq Atabish, all the jury. Thank you so much for this opportunity and for this honor. I'm so grateful. Thank you.
You're welcome, Zainab.
الحقيقة بنشكر جدا الدكتور مازن الحقيقة على التجميع الجميلة، وأنا الحقيقة امبرسد بالمستوى، وفوجئنا فعلا بالمستوى عالي جدا جدا، لدرجة أنا كنت قايل لحضرتك أنا هقعد ساعة بس ما قدرتش أقوم بصراحة من الحلاوة بتاعة توكس الحقيقة، وإن شاء الله تكون فتحة خير بإذن الله.
يا رب. شكرا جزيلا.
إن شاء الله إن شاء الله.
الله يجزيكم الخير على كل جهودكم إن شاء الله. شكرا.
شكرا دكتور مازن.
شكرا جزيلا دكتور مازن.
يعطيكم العافية جميعا.
بأمان الله.
شكرا دكتور مازن.
شكرا دكتور مازن.
شكرا بقية الزملاء. شكرا لجميع الزملاء. أهلا وسهلا.